Hi everyone and welcome to our next video, and it's part 2 of asthma, and today we'll be talking about acute asthma and asthma attacks. So what are the precipitating factors for an asthma attack? Well, they include stress, pets, exercise, pollen, bugs in the home, chemical fumes, cold air, fungus spores, dust, smoke and pollution. What factors increase the risk in children? Well, comorbid atopic conditions, younger age, obesity, and exposure to tobacco smoke all increase the risk. And what about adults? Older age, the female gender, reduced lung function, obesity, smoking, and depression all increase the risk of future attacks. What are the types of acute asthma? Well, there's 5 severity levels. Going from less severe to more severe, we have brittle, moderate, acute severe, life-threatening, and near-fatal attacks. Going through them one by one, we have brittle asthma. There's 2 types. In type 1, you have a wide PEF variability despite intense therapy. And in type 2, you have sudden severe attacks on a background of apparently well-controlled asthma. Moderate asthma. This is characterized by increasing symptoms, no features of acute severe, and a PEF of over 50 to 75%, best or predicted. For acute severe asthma, it's any one of PEF 33 to 50%, best or predicted, inability to complete sentences in one breath, a respiratory rate of over 25 breaths a minute, a heart rate of over 110 beats per minute. You need to admit this patient if they have persisting symptoms even after treatment. The next type is life-threatening, and this is when a patient has any one of the following with severe asthma. PEF less than 33%, best or predicted, silent chest, dysrhythmia, cyanosis, hypotension, confusion, feeble respiratory effort, exhaustion, an SpO2 of less than 92%, a PaO2 of less than 8 kilopascals, a normal PaCO2, bradycardia and coma. And for any of these symptoms, you need to call an anaesthetist by calling 3392 and chest. And finally, near-fatal asthma is where you have a raised PaCO2 and or they're requiring mechanical ventilation with raised inflation pressures. So, management. First, you've got to think about the A, B, C, D, E. So oxygen, you need to give high flow oxygen and aim for saturations of at least 92%. You also need to give IV fluids to rehydrate the patient and to correct their electrolyte imbalance. Reassess them every 15 minutes with peak expiratory flow rate. And what about the drugs? Well, the drugs include oxygen, salbutamol, hydrocortisone or prednisolone, ipratropium bromide, theophylline, and magnesium sulfate. For those last 2, you need to make sure you consult first. So, salbutamol, how do we give it? You give it nebulized with oxygen. That's 2.5 to 5 milligrams every 10 minutes. And the side effects of this include tremor, arrhythmias, and hypokalemia, which is why you need to monitor the patient with an ECG. And what about hydrocortisone? Well, for that, you give it IV 100 to 200 milligrams 4 times a day. Or with prednisolone, you give it orally 40 milligrams and once a day. What about ipratropium bromide? Again, it's nebulized like with salbutamol with oxygen, and you give 500 micrograms every 4 to 6 hours. It's a muscarinic antagonist, so its side effects include arrhythmias, cough, dizziness, dry mouth, headache, and nausea. Magnesium sulfate. Magnesium sulfate is a bronchodilator, so you give it 1.2 to 2 grams over 20 minutes IV. And theophylline. It inhibits phosphodiesterase, which then increases CAMP, relaxes the smooth muscle, and causes bronchodilation. Indications for using this drug include life-threatening asthma attack, and you need to give it with senior guidance. Side effects include palpitations, arrhythmias, nausea, seizures, as well as drug interactions. Monitoring acute asthma. You need to check their peak flow regularly, you need to check their oxygen sats, you need to listen to their chest. The ABG needs to repeat at 1 hour if they're hypoxic, or normohypercapnic, or if the patient deteriorates. In terms of bloods, you want to check their potassium because of the risk of tachycardia and arrhythmias. You also want to check their glucose, and you want to check their ECG because of potassium and magnesium ions, as well as the use of salbutamol. So when do we involve ITU? All patients requiring ventilatory support or with near fatal or life-threatening or acute severe asthma with symptoms that are not improving. These symptoms include worsening peak flow, a persistent or worsening hypoxia, a high PaCO2, low pH, exhaustion, drowsiness, and respiratory arrest. So who is safe to discharge? Patients with a peak expiratory flow of 75% after 1 hour with no other complications are safe to discharge. So, the aim of discharge is to prevent further asthma exacerbations, and there's 3 important parts. You need to check if the patient has improved symptoms, if the patient has improved peak flow, and if follow-up has been arranged. So, improving symptoms. Patients should have clinical signs compatible with home management. They should meet the beta-2 agonist requirements, and therapy can be continued at home. Improved peak flow. Their peak flow should be over at least 75%, their best or predicted, and the diurnal variation has to be below 25%. Finally, you need to sort out a follow-up within 48 hours and less than 30 days post-discharge by a GP or nurse specialist. They need to be under specialist supervision indefinitely for near-fatal asthma and for at least 1 year if they've had a severe asthma attack. Thank you for watching.